Hello, and welcome to part one of a three-part CME-accredited video discussion entitled Community Oncology, Clinical Debates in Breast Cancer, Advanced Estrogen Receptor-Positive Breast Cancer. I'm Dr. Harold Burstein, an Associate Professor of Medicine at Harvard Medical School, and I'll be your moderator for this educational activity. I'm delighted to be joined today by Dr. Stefan Gluck, Distinguished Professor at the Sylvester Comprehensive Cancer Center at the University of Miami. Welcome, and thanks so much for joining us today.
Thank you. Pleasure.
Upon completion of this accredited video segment, you'll be better able to identify predictive factors and markers associated with response or resistance to endocrine therapy, to examine current data regarding the rationale for therapeutic strategies to overcome resistance, and to have better insights into the natural history and treatment options for hormone receptor-positive advanced breast. We'd like to begin our first clinical discussion about predicting response and resistance to endocrine therapy for hormone receptor-positive breast cancer. Let's start with a case, Stefan. This is a patient I actually saw not too long ago in clinic, a 57-year-old woman who had recently been diagnosed with ER-positive metastatic breast cancer. She'd been diagnosed with node-positive breast cancer about 6 years ago. At that time, her tumor was ER-positive, progesterone receptor-positive, and after her surgery for primary breast cancer, she received adjuvant ACT chemotherapy. She then had radiotherapy after her lumpectomy and 5 years of an aromatase inhibitor in the adjuvant setting. More recently, she had developed lower back discomfort, and an MRI had suggested lesions suspicious for metastatic disease. She underwent a CT-guided bone biopsy that unfortunately confirmed metastatic carcinoma. The markers on the tumor this time, ER-positive, PR-negative, HER2-negative, all consistent with advanced breast cancer. A more extensive staging workup showed multiple bone abnormalities throughout the axial skeleton and a question of enlarged mediastinal lymph nodes without evidence for pulmonary or hepatic metastases. So, this is a very common clinical presentation. A woman comes to your office. She now has been diagnosed with advanced breast cancer. It's hormone receptor positive. What are some of the first things you tell such a patient as they begin to process through this diagnosis of recurrent disease, particularly thinking about women who have ER-positive breast cancers?
Yeah, indeed, you're absolutely correct. It's a very common case scenario. We have patients who are postmenopausal, have been diagnosed a few years ago with early breast cancer, treated appropriately and correctly, and yet have a recurrence. Unfortunately, the first thing I usually tell to my patient, I start with that, is that this disease now becomes incurable. And to make her feel better, I tell her there are many diseases that we are treating today and not curing, whether it's diabetes or hypertension. So she starts to understand that she, from now, will be on some kind of treatment or other for the rest of her life. And the goal will be to prolong her life and to improve or maintain her quality of life as much as possible. So that's the principle. And it's nothing new, of course. And the second thing is, because she has been diagnosed with estrogen receptor-positive breast cancer, which we need to assume is sensitive to anti-estrogen treatment, that we can use these compounds in a series over months or even years before we even have to move to chemotherapy or other means.
Right. In fact, the best scenario you'd like at that point is that you could begin to spool out these anti-estrogen therapies moving forward, achieve long periods of tumor control, and then the horizons start expanding as time goes by.
Absolutely. And I also mentioned easily to her that every year or so we get new compounds. So each of our treatment, if it should work, let's say for a year, now we have 5 or 6, and in 5 years maybe have 10 such compounds. So she starts to understand it's not only bad news, it's also some positive news behind it.
Now, this patient falls into a category that we are increasingly recognizing what we call later recurrences in breast cancer. So historically, there's always been a lot of focus on years 0 through 5 after a cancer diagnosis. But it turns out for most ER-positive breast cancers, the greatest jeopardy continues on for another 5 or even longer years. Yeah. Anything atypical about this presentation?
Not really. Especially what I would like to point out is the change of the receptors.
You're talking about the fact that the progesterone receptor went from positive to negative.
Correct.
Yeah. Say more why that's relevant.
Well, as we know, and biology is driving our decision more than ever. We used to look at the size of the cancer and later of the lymph nodes and even later of just the receptors. In the meanwhile, we know there's much, much more behind it, because these receptors, if active, are actually turning on and off other genes and subsequent proteins which may play a role into efficacy of our treatments.
So what's the clinical significance of loss of progesterone receptor, which in my experience happens not infrequently in cases that were originally ER and PR positive? You then rebiopsy at the time of metastasis,
Sure.
and you've seen loss of PR. Is there clinical significance to that?
I believe so. As you of course know, the progesterone receptor is upregulated by a functional estrogen receptor.
Yeah.
What does it mean? It means if I target these receptors with our treatments, tamoxifen or alike, or aromatase inhibitors, then I'm targeting a protein, estrogen receptor, which may or may not be functional. So it probably predicts, and there are some clinical data to support it, the response to therapy if the progesterone receptor actually is or is not upregulated.
Now in this case, because of the bone findings, we pushed to get a bone biopsy, and really that's become our standard approach for almost all instances of likely cancer recurrence. Even historically when we had scans that were, you say that's got to be recurrent cancer. Is that your practice as well, and why do you think it's important to get these biopsies?
I think you touched a very important question. It's probably not so important to confirm that it is a breast cancer metastases, because 99% of all cases will be. But the point is that these receptors, the biology of the cancer, might have changed. And some data support that changes can be in any way, from estrogen positive to negative to positive, including HER2, which is another important receptor, positive to negative and vice versa. And it happens anywhere between 10 and about 35-38% of all cases. So indeed, it became our practice in Miami also to do a biopsy upon recurrence.
I got to say, it's not 99% in my experience. I've certainly found lots of benign bone findings. Once we had a case of tuberculosis. I mean, you do find weird things. And certainly for pulmonary nodules, there are all sorts of other etiologies one wants to explore. Granulomatous disease, second cancers, lung cancer, that kind of thing. But the world has really shifted there, hasn't it? We're almost always getting biopsies now for proving recurrent disease.
Yeah.
So what else about this case is typical or atypical? Let's talk about the sites of metastatic disease being principally bone and possibly lymph node in this case. Again, does that resonate with your experience?
Absolutely, yes. Breast cancer that is driven by the estrogen receptor, so ER positive, whether it's PR or not positive, most of the time, I would think about 60% goes to the bone, sometimes to other organs, and over time, of course, yes, in other organs, but initially the presentation is bone.
Yeah. My colleague at Dana-Farber, Nancy Lin, has been looking at this in some NCCN registries, and clearly the biological subset of breast cancer dramatically affects those tissue tropisms. So she has shown that triple-negative breast cancer is HER2-positive disease, far more likely to go to the viscera, the lung, the liver, the brain as their initial site of presentation, whereas ER-positive tumors more likely to go to bone and soft tissue or lymph node, as we saw here. So the patient has met you, you've talked about the goals of care, she understands it's a situation where you're going to be managing this with lots of different treatments over time. Does she need chemotherapy right now, or should she start on an endocrine treatment or use both?
That's a key question that the patient will ask, do I need more chemo? And of course, nobody likes to have the answer as yes. As long as the patient doesn't have a very fast-growing tumor, as long as she doesn't have a visceral crisis, as we call it, so big tumors in the lung, in the mediastinum, or in the liver, or as long as it's estrogen receptor positive, I think it's absolutely appropriate not to use chemotherapy, as long as possible. And actually in our institution, together with investigators from Baylor College and from Vanderbilt, we have published a paper last year to identify exactly this. We are more and more able, with a number of different compounds, to push the chemotherapy initiation as far as possible to the late stages.
Really, that should be the endpoint for all these endocrine trials, which is how long
Yes.
can you delay the time until the patient needs chemotherapy? And that would be our approach as well. One of the things I try to emphasize for patients at this point is that they have a relatively modest disease burden, in this case, relatively few symptoms, and we'd like to see what endocrine therapy can accomplish, and that there really isn't the need to pull the trigger for chemotherapy right away. So let's say we were to start a patient like this on next-line endocrine therapy. What sort of things would you be following or telling the patient to look for as you initiate such treatments?
Well, obviously, you need to explain the side effects of the treatment that you are, or anticipated side effects of the treatment that you are suggesting. And of course, the most important thing for the patient is symptoms. As long as symptoms are under control or improving or disappearing, then actually you know better than any scans that the patient is doing well and responding to treatment. Now, having said this, we of course need to, particularly in such a case, use other compounds in endocrine treatment, such as bone targeting agents,
right,
to improve the bone strength, to avoid fractures, to avoid bone-related side effects.
So this patient would begin either denosumab or zoledronic acid
Correct.
or something like that as part of their treatment. You know, one of the things I always have a hard time explaining to patients is how difficult it is to follow cancer in the bones. You know, bone scans are notoriously fickle.
Yes.
We try not to use tumor markers too much. They fluctuate a lot.
Yes.
I like your point that really it's the symptoms that often tell us what's happening within the patient's body and how the tumor might be responding to treatment. So what kind of surveillance would you offer a patient in a situation here?
Well, at the end of the day, seeing her frequently enough to assess the side effects and the presumable clinical improvement of her symptoms. Now and then, and it depends where the sites of metastases are, you need some imaging. And as you mentioned yourself already, bone scan is probably the worst that you can use. Simply because, first of all, it's lagging behind.
Do you get CAT scans and bone scans, or do you get PET CT scans?
Well, sometimes we do PET CT scans, but I prefer myself CT scans.
Yeah.
And if indicated, of course, MRI is particular for the spine.
Right.
Because this is where your imaging may predict fracture and very bad problems coming from that. Yeah.
Okay, so we have this patient. We're going to begin her on a bone-modifying agent. We're going to start our next line of endocrine therapy. She comes back a couple weeks later. Now's a chance, I always find, to begin a dialogue about sort of what to expect and what kind of prognostic features there are. So let's just sort of walk through some of the other prognostic features in advanced breast cancer like this. So the tumor is still ER positive, that's favorable. It's HER2 negative, which would be favorable in the long run. She has bone dominant disease, and in my experience, these cases tend to do better than patients who have visceral metastasis. She has a reasonably long disease-free interval. So, you know, a 6-year time course between her original diagnosis often correlates with a more indolent, slower growing cancer. So I think a patient like this needs to be reassured as best one can that, you know, this is going to be a thing that plays out over a long period of time, that there is still much great living yet to be done, and that, you know, our fond hope is that the treatments that we initiate will begin to play out and have some efficacy. How long, in your experience, does a first-line hormone therapy work in a situation like this?
Well, there are two answers, experience and clinical trials. If you look at clinical trials and look at data showing duration of response or time to progression on these first-line trials, it's usually several months, anywhere between 6 and 9 months, occasionally a year, if the study is exceptionally good in outcomes. In my own experience, it actually can be longer. And very often longer. One of my fellows just published a case with me of 18 years of endocrine
18 years.
18 years of endocrine treatment. That's an exception.
You were a child when you began therapy for that patient.
Thank you. I'm a grandfather now. So, and it was not my patients initially, of course.
I have a patient who was a young woman, had been diagnosed with advanced disease in her liver, actually, in the mid-90s. And she actually had a bone marrow transplant back when we were doing that for advanced breast cancer. And months later, had progression, biopsy-proven recurrence in liver. We began endocrine therapy. And 14 years on, she is doing really well. And, you know, I wish I understood the biology, but it's a hopeful measure for patients to see things like that.
Maybe we also should communicate with our colleagues that patients are asking for treat me aggressively. Yes. Aggressive usually means lots of chemo. Aggressive treatment doesn't mean effective treatment.
Right.
And as you just indicated, patients who have estrogen responsive or anti-estrogen responsive disease actually have more benefit from anti-estrogen treatment than from chemotherapy.
It's a point lost because everybody gets so caught up in the idea of using the heavy artillery.
Yes.
So let's say we did this for 4 to 6 months and she's had stabilization of her findings radiologically as opposed to a response. Is that a clinically important difference in terms of her outcome down the road?
Well, the worst case scenario to indirectly answer is if she does not respond.
So progression, obviously.
Progression within 3 to 6 months of first-line treatment is a bad sign for hormone receptor positive breast cancer.
Right.
Everything else actually is pretty good, and we have some data to support it. If you have a complete or partial remission, and in bone complete most likely doesn't exist, but partial remission or stabilization of disease, which means 6 months not progressing, actually outcomes are pretty good.
And they're the same as if you have stabilization of disease,
Absolutely.
right? I mean, that's the key point.
Yep.
Again, we often see in tumor board discussions, you know, the things haven't really changed till we shift to chemo, and the answer is no. Stabilization is, under these circumstances is a good outcome. Well, let's try and review that case one more time. Again, this was a woman who had had chemotherapy in the adjuvant setting, 5 years of an aromatase inhibitor, and now we're talking about predictors of outcome. The choices would be extent of prior endocrine therapy, disease-free interval, overexpression of HER2, quantitative measurements of ER, lack of PR expression, all of the above, or only A, C, or D. Well, that's a tough question, but tell me on this list, what's the answer for which of these would predict outcome?
Well, basically, each of these points have a valid statement. Probably the least well investigated is the quantitative levels of ER. Why? There are studies from the 80s and early 90s where we measured the estrogen receptor by femtomoles.
Yeah.
So basically the weight, how much can we measure? But we got completely away from this. But in those studies in the 80s and 90s, actually there is a response correlation to the amount of femtomoles, so the amount of
So the higher the level of ER, there was a much more dramatic likelihood of response to what was principally tamoxifen in those trials.
More recently, we have looked only on a slide with IHC, immunohistochemistry, and looking the expression of the cancer cells, whether or not they have it, estrogen receptor, and there are a number of ways to measure it. The most recent, endorsed by CAP and ASCO guidelines, is if a cancer has 1%, and we use it, 1% or more cells expressed, it's regarded positive. If not, it's negative. So we have a yes and no answer.
Dichotomous.
Dichotomous.
So I would say the correct answer here is all of the above. And with that, we'll move to some takeaways from this segment of our education program. Can we predict responses or resistance, and what can we tell patients who are newly diagnosed with advanced breast cancer? First, there are a lot of familiar clinical factors that predict the likelihood of benefit from endocrine treatment. These include the disease-free interval, the expression of hormone receptors, the absence or presence of HER2 overexpression, and the sites of disease, not so much predicting the likelihood of response, but predicting the ultimate outcome. To date, so far, molecular diagnostics have not really advanced that in the management of advanced or metastatic breast cancer, though there's a lot of work going on in that area. And again, something I think it's always important to remind patients at this juncture that the clinical history governs a lot of what's likely to play out down the road. So in a case like this, where you're talking about a recurrence 6 years after treatment, when you have a variety of endocrine therapies available yet to go, one can be much more optimistic as you get going than in other circumstances. That concludes the first segment of our three-part debate series. I want to thank Stefan Gluck for joining me for this presentation. I hope you've enjoyed it. To receive credit for this CME video debate and series, please complete the post-test and evaluation. Thank you very much for joining us today.